Good afternoon, everyone. Welcome to Ethics for Lunch for November. My name is Mark Hughes. I'm co-chair of the Ethics Committee at the hospital and a faculty member at the Berman Institute of Bioethics. As many of you are aware, Ethics for Lunch is our monthly series where we engage with the hospital community to talk about issues that are relevant to the hospital in regard to clinical ethics and patient care. This month, we certainly have a hot topic, and I'm glad that you've been able to join us for discussion about the COVID-19 vaccine and the ethical principles with regard to its allocation and distribution. Just a reminder that the Ethics for Lunch is sponsored both by the Ethics Committee and the Berman Institute, and we are recording these sessions. And the recording will be available on the Berman Institute website in the next few days. If you wish to get CME credits, you can text that code 29858 to the phone number that's at the top of the screen. And we will go ahead and get started. So we'll go to the next slide. I'll talk about the objectives for today. So as I mentioned, we want to talk about the main ethical principles with regard to the allocation and distribution of the vaccine. We're going to learn a little bit more about the vaccines themselves, and we've gotten news in the past week about two vaccines, one with 90% effectiveness and the other with 95%. So we're excited about that and hope that that projects a light at the end of the tunnel. And then after learning about sort of the science and how vaccines work, we will talk about some of the recommendations that have come out from various bodies, most especially here at Johns Hopkins from the Center for Health Security. So want to talk a little bit first about the plan that we have for Hopkins. Just our general framework and when we're drafting a policy, if we do get an allotment of vaccine. So first of all, this is going to be for the entire Johns Hopkins health system. It is the case that if it's a hospital such as Sibley down in DC or All Children's down in Florida, there may be different mandates based on that jurisdiction. So we may not fully relate to, across the health system. But we're trying to coordinate the care and the vaccine distribution across all sites. We are going to try to work with other health systems in Maryland and coordinate our efforts as much as possible, and the Maryland Hospital Association and others at the state level so that we are working together to get the vaccine out there. And our general approach is going to be, because there's going to be a big demand with the supply gradually increasing over time, but the initial supply will not be enough to meet the demand. Having a tiered approach for prioritization about who would get the vaccine or at least be offered the vaccine first, and then work down the list for the next tiers. We'll go to the next slide. So our policy at Hopkins is based on both the recommendations that have been made by the National Academy of Medicine, from the CDC, and eventually ACIP, as well as I said, the Center for Health Security here. Obviously, we're going to rely on the best known scientific evidence and use consensus opinion. We have experts here that can help inform, how to interpret the science that is being put out as part of Operation Warp Speed, and then really making sure we are attending to the core ethical principles and our obligations to all the various stakeholders we have within the health system, not only the employees of Johns Hopkins, but our patients, students, and then also by extension, our larger family of family members and of the employees and students, and really trying to make sure that everyone has an opportunity to get the vaccine if they wish to get it. Next slide. So we do have some prior experience in developing frameworks. So back in 2009, with the H1N1 influenza A vaccine, We also needed to think about a tiered approach, and you'll just see a brief schematic of how that worked. Now, that was a different vaccine and different circumstances with influenza, where in that case, there was also concerns about children receiving, getting influenza, as well as being able to transmit it to others. That's less of a concern with COVID. But it had this tiered approach in terms of who is at risk, high risk to moderate risk to low risk, and then working your way down across these not only risks, but also different segments of the population, whether it's healthcare workers who might be exposed to patients with influenza, then the patients themselves, then other employees, students, and family members. So a little different approach for COVID, and we're going to hear more about the COVID vaccine. And I'm going to turn it over to Anna Durbin, and she will talk to you about the science of vaccines.
Thanks so much. Can you advance my slides for me? That's great. We can go advance to the next slide. Next slide, if you can.
Okay, Anna.
So actually, right, so
do you want to disclose your item?
Yeah.
Okay.
Yes, I can just say that I'm the principal investigator of the AstraZeneca phase 3 trial here at Hopkins, not the overall principal investigator, and I've worked on Pfizer phase 3 clinical trials. So I am going to talk just very, very briefly about vaccines, because we have had some really great news, not only I would say for COVID vaccines specifically, but for vaccine development in general. And what you're seeing here on the left side of the slide is just the different vaccine platforms that have been proposed and put into use for COVID vaccine development. And as you can see, there are multiple different platforms. In the light orange is live virus, going down to virus vector, nucleic acid, which is the mRNA vaccines, which we're all very excited about given the recent results. And I will say all of these different platforms and the multiple vaccines that are utilizing them have a very similar approach, in that the coronavirus spike protein is the target antigen. So all of these vaccines are essentially expressing the spike protein of coronavirus as target antigen. And I think what's also really important about this is that with science that grew out of SARS-CoV-1 and MERS, scientists have realized that they can make this spike protein in a conformation that is much more immunogenic than previous vaccine candidates. And I think that's really important. We have at least 5 candidate vaccines that are currently in phase 3 clinical trial. This is unheard of, given that we just knew the sequence of the virus in January, and we already have phase 3 efficacy results, be it preliminary, on 2 of these vaccine candidates. Next slide. So these are the different vaccine platforms, and it's just an illustration that takes you through how these vaccines work. The first 2 that went into clinical trial are the messenger or mRNA vaccines. They are produced by both Moderna and Pfizer. I want to note that the Moderna vaccine was developed in collaboration with the Vaccine Research Center at the National Institutes of Health. And this essentially, the vaccines are really just comprised of messenger RNA that will then, once injected into the body, will allow your own cells to essentially make and process that spike protein and present it to your immune cells, so that your body thinks it's seeing the real virus spike protein, when really it's a vaccine. And we're hopeful that these platforms, based on how they work, will induce not only antibody, but also a T-cell immune response. The next advanced platforms are the virus vectored platforms that include the chimp adenovirus vector, which is the ChAd-Ad, the ChAd-OX3, and that's where chimpanzee adenovirus is expressing the spike protein of SARS-CoV-2. A Janssen vaccine, which is an adenovirus type 26, expressing the spike protein of coronavirus type 2. And then the Merck VSV vectored vaccine. And what's interesting about the Merck vaccine is this platform has already been licensed for an Ebola vaccine. So we think that that's going to move through the regulatory process much more quickly than some of the newer platforms. And then we have two vaccines that are what we call subunit protein vaccines made by Novavax and Sanofi. The Novavax vaccine is starting very, very shortly, and it's presumed that the Sanofi vaccine trial will begin the end of December or early January. Next slide, please. So I just want to just comment briefly on efficacy versus effectiveness, because we've had some very, very good efficacy results for both the Moderna vaccine and the Pfizer vaccine. And these efficacy results come from carefully controlled vaccine trials where we know that the volunteers got the vaccine at the time they were supposed to get the vaccine. They were followed very closely, and illness was captured quickly, and the endpoints of the trial were or the endpoints of clinical illness were able to be captured and well documented. Both of these vaccines, the Moderna and the Pfizer vaccine, require 2 doses. So only those volunteers who received both doses of vaccine, and only those cases that were captured either 14 or 21 days post the second dose of vaccine, were included in the analysis. So we call this sort of the best case scenario. And I will say that the efficacy results were excellent. Both Moderna and Pfizer had about 95% efficacy, and the Moderna vaccine trial efficacy results included efficacy against severe COVID, which is really excellent. Effectiveness, though, is the real world performance. So people may not get both doses, it may not be given correctly, and generally the effectiveness is not as robust, or the results not as good as efficacy trial. We also don't know the long-term durability of efficacy with these vaccines, which is really going to be under study as time goes by. All of these clinical trials are using double-blind placebo controls. Each will enroll at least 30,000 volunteers, and they're randomized 1-to-1 or 2-to-1 vaccine to placebo. Now, as investigators involved in these trials, I will say we have an ethical question now that we know that both the Moderna vaccine and the Pfizer vaccine are efficacious. How do we handle placebo recipients in that group? And if we have time later on, that's something that I can discuss a little bit, because it is something that Operation Warp Speed is tackling right now to make sure that we handle that in a very ethical and safe manner for all the placebo recipients. Thank you.
I'll turn it over to Ann Barnhill to talk about some of the issues in terms of the ethical principles underlying this.
Okay. Great. Thank you. Let me just start my slideshow. Okay, great. I'll be talking about the ethics of allocating scarce COVID vaccine between population groups and what different working groups and committees have said about that. And what I'm saying is not specific to allocation decisions at the Hopkins level or the institutional level. So the basic question is, if there isn't enough COVID-19 vaccine initially when a vaccine is approved to offer vaccine to all who want it, which population groups should be offered vaccine first? And as more vaccine is successively available, which group should be offered vaccine next, in what order? And we had a working group here at Hopkins that looked at this, and I'll talk about the framework we created. And at the national level, there was a National Academies committee created, which wrote a report that made allocation recommendations. And then there's also the CDC's Advisory Committee on Immunization Practices, which will be making recommendations. And they're an independent advisory body that makes the recommendations about vaccine use that the CDC adopts. Okay. So we had an interdisciplinary working group here at Hopkins out of the Center for Health Security and led by Dr. Eric Toner. And what our working group, one of the things our working group came up with was this ethical framework for vaccine allocation decisions, which we hoped could inform others' deliberations and decision-making about vaccine allocation. So I'm gonna first spend a few minutes just explaining our ethical framework and just kind of explaining how we think about the ethics of allocating vaccine. So in our framework, we started with ethical fundamentals, so basic broad ethical values, and kind of went from those broad ethical values all the way to recommendations. or showed how you get all the way from those to recommendations for specific groups to prioritize. So we identified 2 broad ethical values that we think should guide allocation. The first is promote the common good. So use vaccine in ways that benefit people and promote the common good. And then the second ethical value is treat people fairly and promote equity. So use vaccine in ways that are fair and promote equity. And then we also identified a third ethical value to guide decision-making about vaccine allocation and to guide vaccine distribution. And that is promote legitimacy, trust, and sense of ownership in a pluralistic society. So this value is really a value that's meant to guide the process, like the process of making decisions about vaccines, and the process of distribution should promote legitimacy and should promote trust and should respect the diversity of views we see in a pluralistic society. Okay, and so what we did is under these 2 broad ethical values, we identified more specific ethical principles that follow from those values and advance those values. And in this table over here to the left, it's the table from our report, you can see this spelled out. And then we identified more specific policy goals and objectives that follow from these values and principles. And then finally, we identify priority groups. So groups whose, if you prioritize them for vaccine, would advance these policy objectives we identify. Okay, so for example, under this broad ethical value of promote the common good, we identified 2 more specific ethical principles: promote public health and promote economic and social well-being. And then under these ethical principles are more specific goals, like policy goals that advance those principles. So for example, under promote public health are the goals: prevent COVID-related illness and death, prevent injury, illness, and death from other causes, and protect the health system. And then under the ethical principle, promote economic and social well-being, there are the policy goals of protect essential services, enable economic activity more broadly, and enable children to return to school and childcare. Okay, and then our other broad ethical value is to treat people fairly and promote equity. And under this broad ethical value, we identified 3 ethical principles that advance that value of fairness and equity. And the first is address background and emerging inequities between groups. So for example, address the higher rates of COVID illness and death we're seeing in many communities of color. So that's an emerging inequity rooted in background inequities. And the next principle here is to give priority to the worst off individuals. And then the third principle here is reciprocity. And reciprocity here is about like recognizing the sacrifice that essential workers have been making because they've been taking on risk to benefit all of us, and showing reciprocity to them by offering them the protection of vaccines. Okay, so these are like 3 ethical principles that identify 3 distinct and important ways in which people can be treated fairly or equity can be promoted in the allocation of COVID vaccine. All right, so I don't really have time to go through the framework in all of its beautiful detail, but to make a long story short, we identify policy goals and objectives, and then we identify priority groups for all the policy objectives. So we identify groups of people who, if you prioritize them for vaccination, that will advance the policy objectives. And then we do this for all of our policy objectives, and then we have a number of different potential priority groups who could be prioritized for vaccination. And then one thing to consider is, whether there are some groups whose prioritization advances multiple policy objectives. And we see that with healthcare workers and other essential workers, prioritizing them advances multiple policy objectives, like targeting people who are at high risk of infection and protecting essential services and reciprocity. But then we also look and see, are there trade-offs between different policy objectives? And if there are trade-offs, then you have to figure out, how do you balance those trade-offs? So how do 2 different objectives, how should those be balanced? Which is more important? Okay, and our report did not make firm recommendations about priority groups. And that was because, we say in the report that we think allocation decisions should emerge from a process of public deliberation, but also how to allocate a vaccine may depend upon, may depend upon features of the vaccines that ultimately get approved and used. Okay, so we didn't make firm recommendations. However, we did give an example, of how one might take our framework and apply it and use it to identify priority groups. And so here in this table from our report is that example. And so here we identify, 3 broad groups for the highest priority for a COVID vaccine. And they are those most essential in sustaining the ongoing COVID-19 response, and those at greatest risk of severe illness and death, and their caregivers, and those most essential to maintaining core societal functions. Okay, so that is our framework. And now quickly, I just want to run through what the National Academies Committee did in their report. So they released this great report in October. And they had an ethical framework too, or they had a framework that was rooted in foundational ethical principles as well. And their ethical principles were maximum benefit, equal concern, and mitigation of health inequities. So those might sound kind of familiar, kind of similar ethical foundations. And then they developed these 4 criteria that they use to prioritize among population groups. And these 4 criteria are risk-based criteria. So the first one is risk of acquiring infection. So individuals have higher priority to the extent that they have a greater probability of being in settings where SARS-CoV-2 is circulating and of being exposed to a sufficient dose of the virus. And then the second risk criteria is the risk of severe morbidity and mortality. And the third one is risk of negative societal impact. So like the risk that if that individual gets sick or ill, that would have negative effects on other people. And so here, like frontline healthcare workers, there'd be a big risk of negative societal impact. And then the last risk dimension is risk of transmitting infection to others. And then the report takes these 4 risk-based criteria, these 4 dimensions of risk, and considers different groups' typical level of risk along each of these 4 dimensions. And so you'll see here, like the first row, high risk health workers, high risk of acquiring infection, medium risk of severe morbidity and mortality, high risk of negative societal impact if they fall ill, high risk of transmitting infection to others. Okay, so they do this for various groups. And then based upon that, they came up with this vaccine allocation recommendations, these phases. And phase 1 has these 2 groups, phase 1A, which is about 5% of the US population. And that includes high-risk health workers who are involved in direct patient care, including those providing care in nursing homes and home health workers, and those in healthcare facility services and first responders are also included. And then phase 1-2, which is approximately 10% of the US population, includes people of all ages with 2 or more comorbid or underlying health conditions that put them at significantly higher risk, and all older adults living in congregate settings or overcrowded settings. And that would include nursing homes, prisons, group homes, et cetera. And then their second phase, phase 2, is about 30 to 35% of the US population. And that includes K-12 teachers and school workers, critical workers in high-risk settings, people of all ages with comorbid and underlying conditions that put them at moderately higher risk, and people who live and work in high-density settings like homeless shelters or prisons, and all older adults. Okay, and then another interesting feature here, so you'll notice this brown box or oval, which reads, equity is a cross-cutting consideration. In each population group, vaccine access should be prioritized for geographic areas identified through CDC's Social Vulnerability Index or another more specific index. And the Social Vulnerability Index is an index which is used to identify communities that are most endangered and in need of aid during disasters. And it takes into account poverty, unemployment, health insurance rates, housing, transportation vulnerabilities, and other socioeconomic and demographic factors. So a lot of different like social determinants of health. And the report makes 2 recommendations here. So one is that perhaps the federal government could reserve 10% of the total federal allocation of vaccine, and rather than distributing it all to the states, use it on areas with a high social vulnerability index and or use it on hotspots. And then second, they recommend that states and localities make special efforts to deliver vaccine to residents of high vulnerability areas. Okay. All right, so now moving right along, the Advisory Committee on Immunization Practices, they won't make recommendations until a vaccine is approved, but they have indicated, some of the groups, some of the potential allocation groups they're considering. And whoops, let's go back. Their phase 1A is healthcare personnel, paid and unpaid persons serving in health settings with potential for direct or indirect exposure, about 20 million people. And their phase 1B is this very large group of essential workers and people with high risk medical conditions and elderly people. So, maybe around 200 million people total. And that's because that's so many people, further prioritization within that group will likely be needed. Okay. All right, before I finish, I just want to highlight what I think are two hard issues, hard and or interesting issues, ethical and empirical issues. And the first one is, what's the best way to address social disadvantage and racial inequity in vaccine allocation? So there's been some discussion in the literature about whether we should directly prioritize people from racial and ethnic groups with higher COVID burden. And that would include people who are Black, Latino, American Indian and Alaska Native, and Native Hawaiian and Pacific Islander. So for example, when you're in phase 1 and healthcare workers are being offered vaccine, or whatever group of high priority people are being offered vaccine, then you would offer it first to the healthcare workers who are from these racial or ethnic groups. But some legal experts have questioned whether that would be legal. And there's concern that it might undermine trust. Like people may feel like they're being used as guinea pigs for this brand new vaccine. And so then another approach is the one that is recommended in the National Academy's report. And that's where you allocate more vaccine to geographic areas, that have higher social vulnerability index or some other measure of social disadvantage. But my thought there is that even if this happens, will vaccine be equitably allocated within those areas, like on the ground? So for example, we still could see like physicians could generally end up getting vaccine before home health aides, where home health aides are this group of people, with high exposure and also generally low paid workers and a lot of social vulnerability. Okay, so I think it's interesting to think about, are there other ways to address social disadvantage and in particular racial inequity? Okay, and the second hard issue I want to highlight is this. Do we save the most lives by prioritizing those most vulnerable to COVID or by prioritizing high transmitters? So we could use early vaccine to protect those who are at highest risk of severe COVID illness and death. We could use vaccine to protect the most vulnerable members of the herd, or we could use some early vaccine on high transmitters, like those most likely to propel transmission through the herd. And maybe that's younger people who are more likely to be asymptomatic spreaders, particularly if they live or work in high contact settings. And if we leverage early vaccine to drive down transmission rates, as much as possible, as quickly as possible, could that actually save more lives in the end? So basically the question is, which approach saves more lives? Direct protection of the most vulnerable by vaccinating them, or indirect protection of the most vulnerable by reducing transmission? And this assumes, this indirect protection strategy assumes we can identify high transmitters and assumes that, an approved vaccine actually reduces transmission. And there's been some modeling work that's been done and is trying to figure out, in different contexts, which strategy saves the most lives and also which saves the most life years and which minimizes cumulative incidence of the virus. All right, I will stop there and hand it over to Ruth, I think.
Hi, everybody. I have only one slide, or two slides, I guess, which I'm going to share in just a moment. My perspective comes at this point very much from a global standpoint. And if there's time and discussion, if there's interest, I'm happy to talk about the way in which these same sets of ethical principles, considerations, and objectives are playing out globally as well as within countries. There's a WHO process that is parallel to the process that's going on within countries, and a lot of crosstalk between the two, providing guidance both within countries, but also vaccine allocation globally between countries. But in my few minutes, I'm actually going to do the opposite. I'm going to drill down and just provocatively try to raise a few questions following on Anne's similarly provocative questions about what kinds of issues we're going to face here and how to think about them. So as Anne has already mentioned, the guidance from the National Academies focuses on high-risk health workers first. So that's going to be a challenge for us at Johns Hopkins to define who counts as high risk. This is from the Occupational Safety and Health Administration, this first slide that just gives you kind of generic classification definitions for from low exposure to very high exposure, not so much specific to healthcare. Suzanne, if you could just advance to the second slide. So here it gets a little more granular. And if you look to see, again, while this was not developed specifically for healthcare, some health personnel show up obviously in the very high risk category. Now, the International Labor Organization, I don't have a slide for this because it's not yet publicly available, is about to come out with more granular still operational definitions for health workers as to who counts as low, medium, high, and very high. So to give you some examples, if you look at the medium risk category here for OSHA, and I want you all to be thinking about your own jobs, the International Labor Organization is going to propose a definition that says that if you are working as a health worker in a community where there is community transmission of COVID-19, you are at medium risk if you are in close contact with others in a busy work area, but right, you are not directly providing care to or interacting with people known or suspected of having COVID-19. So a medium risk health worker would be someone who's got a lot of contact with the general public, but no direct responsibility for providing care or interacting with people who are known or suspected to have COVID-19. Now, I just want us to pause for a minute and tell us how we're supposed to figure out who in the general public is suspected of having COVID-19 infection. So this is just not so much an ethics matter as an operational matter. Suzanne, if you would just, that's it for the slides. So with us all trying to figure out whether we're, low risk, medium risk, high risk, or very high risk in terms of our occupational exposure, the next thing I want to raise, and this follows on very nicely from what Anne has introduced, is the recognition that what makes a person at elevated risk has multiple components. There's elevated risk of exposure and thus of infection, and there's elevated risk of severe disease or death should you become infected. And for health workers, obviously both apply. So this categorization that I've just shown you of from low to very high risk is speaking only of one way in which health workers are at elevated risk, and that's because of occupational exposure that could put them at elevated risk of infection. But it's also the case that health workers are not all in the same bucket. We're not all the same with respect to other sources of potential exposure to infection. So we could classify everybody as medium risk, say, in terms of their occupational exposure, but they may not be at the same, everybody who's medium risk from an occupational standpoint, or even high risk from an occupational standpoint, is not going to be at medium or high or the same risk with respect to acquiring the infection outside of work. So living conditions, the density of one's living conditions, both in a neighborhood and in a home, how you commute to work, alone in a car, in public transportation, all of these things will affect an individual health worker's, this is all common sense, we all know this, will affect an individual health worker's actual combined risk of infection. Like there's the occupational exposure, and then there's the risk of becoming infected in the rest of your life. And the question for a healthcare institution is whether we should take into account that second sources of risk of infection, especially when those second sources of risk of infection will travel with background inequities in the way in which our society is structured. So people who have less income are more likely to be coming to work in shared modes of transportation. They're more likely to live in dense neighborhoods, and they're more likely to live in households where there are more people per room. in the household. So for all of these reasons, do we take that into account? All right, so that's just for all of us to think about it. Should we take occupational risk only into account, or should we take occupational risk as well as risk of exposure outside of work into account when we are initially allocating vaccine? Relatedly, health workers are not the same with respect to their risk of becoming seriously ill if they become infected. So we all know, of course, that age is a very critical risk factor for severe disease and death. So is gender. So are several comorbidities, in particular diabetes, obesity, heart failure. We can run through the list. And so is pregnancy. So the next level of question is whether we ought to take into account, as we allocate vaccine in the initial days when it will be scarce within our own health worker community, these factors as well, right? Do we want to allocate not only based on occupational risk, what level of occupational risk from low to very high? Do we want to do it within risk categories by personal or biological characteristics? And do we want to take that put people at elevated risk of disease and death? And then also, do we want to take account of their living and life circumstances outside of work in terms of exposure? With comorbidities, as with risk of infection that comes from differences in the way in which we are able to live our personal lives, there are inequities, right, that it set us up. So we know that certain comorbidities are disproportionately represented in people of color and in people who are low income. And the root causes for all of this are all the same. We don't have time to discuss it. The challenge for all of us is to think through whether we should be taking account of these factors as we distribute vaccine within our own community in the early days when it becomes available. The related question is, as we move outward from health workers who are at high risk or very high risk within our community, we're going to be dealing with general categories, as Anne has outlined, that will be prioritized, like characteristics, groups that are defined by comorbidities, groups that are defined by their essential worker status, groups that are defined by their risk of infection or of onward transmission. And we're going to have to address questions like, should we prioritize members of our own community who fall within an otherwise group whose ticket has come up, right, over other people whose tickets have come up? So let's assume we're at the point in the prioritization process when young adults have been prioritized for vaccine, either because, as Anna suggested, a policy decision has been taken that the vaccine should now at this point be deployed to interrupt transmission rather than to reduce disease and death among those who are at higher risk. And so younger adults are prioritized, right, for vaccine. Should we, within that, as a healthcare institution, but also an educational institution, be prioritizing our own young adult employees, staff, and students over young adults who are in the surrounding community or who are family members of Hopkins staff, faculty, and students, and so on? So all of this is to say that the work that's being done by the various global and national advisory committees, all great, all really, really important. They provide sort of background guidance that's extremely helpful. The work that's going to be done locally, however, by committees of the sort that Dr. Hughes sits on, will have to deal with these issues at an extremely granular level, and hopefully with input from all of the rest of us. So now that I've gotten everybody kind of anxious about how this is all going to happen and all the difficult choices that are yet to be made, I just want to conclude by underscoring one point, which is in the US, and Anna can speak to this in a very informed way, we are really fortunate in contrast to many other people living in other parts of the world. Our prioritization problem is short-lived. We are talking about how to prioritize vaccine over a reasonably short time if all goes well. We should have enough vaccine of enough quality for everyone in the US who wants it, and hopefully for people who now don't want it, who will come to want it later on. So we're talking in the US about prioritization over time. We should all get our crack at this vaccine, in contrast to other parts of the world where the debate is prioritization for all time, right? There's a recognition that there will not be enough vaccine for everyone who will want it, or it'll be extremely unlikely that that's the case. And the prioritization decisions there will be much more difficult and much more consequential. So I'll stop with that. And I think, Mark, you lead us in discussion at this point, or moderate the discussion.
Yes, thank you. So I want to open it up for questions. You can type those into the Q&A or the chat. We have a few already, and I'll just take them in order and get the panelists to respond. So the first was, and especially with regard to health equity concerns and attention to disadvantaged populations, how do you prevent gaming the system by those that have advantages within society, or are rich, or in high income community? So any suggestions about regulations or ways to prevent gaming of the system?
Yeah. So I'll just jump in and say that corruption and cronyism are deeply worrying threats to the overall integrity and fairness of the process. And it's not a small worry. The WHO has explicitly included in its values framework and in its prioritization roadmap big sort of warning statements and signals to watch out for cronyism and corruption. It's to be expected. We all need to take a deep breath and realize that it's a risk not only in countries that have unstable governments or autocratic histories. It's a risk everywhere, and it's going to be a temptation every place. So I'm going to stop and let some of my colleagues on the panel speak to this, but we're going to have these issues within institutions like Johns Hopkins as well. We're not all equally positioned, and there will have to be some serious attention, as I know there will be, to transparency in that regard. But I'm going to stop. I have a lot to say on this, but I'm not going to go there. Right.
I just want to comment and follow up on what Ruth just said, because which is why MASS currently conducting COVID vaccine trials right now, and that is a huge concern of the communities we're working with. They feel that they are at risk for being disadvantaged when a vaccine comes out. A lot of them feel that they've been disadvantaged, and there's a lack of access to healthcare, a lack of access to this vaccine. And really, we are on high alert. When we talk with the community members, we are on high alert about this. They want to make sure that if a vaccine is deemed to be safe and efficacious, that they will have a seat at the table. And if we fail them, it's going to be, I don't even want to go there, but I will say that everybody, members of the community, want to ensure that their community will have access to these vaccines, and they feel they haven't in the past.
There was another one that may get to this trust issue. So two principles when you're thinking about these ethical frameworks. If you want to address inequity, but you're then offering a vaccine to population that might have a historic distrust, how do you make sure you're not undermining trust by addressing the inequity?
So, Anne, do you want to speak to that, or I can?
Yeah, or just, I think this questioner really put their finger on it. I think this is a real issue that is under discussion and that people are worried about. And I think that, then one response to that is one allocation, one feature of allocation that people are concerned will particularly cause that is the kind of direct prioritization of people from racial and ethnic groups. And so, as I was mentioning, one way to try and avoid that bad outcome where you undermine trust through your good intentioned efforts to address inequity, is to prioritize geographic areas that have higher rates of social disadvantage. And those could be measures of social disadvantage that do or don't take race into account. And so, that's one way to try and less directly, but still meaningfully address equity. That's one way to do it. But I think the general kind of question, sort of deeper or more general question about allocation schemes that this question is getting at, how do you resolve tension between two principles in a multi-principle ethical framework? So that's just always the challenge and the work. And I think that, there could often be multiple ways to resolve the tensions, all of which are reasonable and justifiable, and different groups might resolve the tension differently. And in different societies, there may be different ways of resolving the tension or different ways of, weighting certain considerations over others, which would make sense. And just one more comment about that. I think here we actually see a kind of, to some extent, a welcome alignment broadly of the kind of utilitarian doing good ethical value and fairness ethical value. Because, for example, essential workers, you have communities of color that are overrepresented among essential workers who also have the highest COVID burdens. And so prioritizing essential workers really gets you both, right? Is kind of fair as well on the promoting the common good dimension and also on the equity dimension.
Come to the one about, maybe we'll address the one about when you have multiple, Ruth sort of posed this, multiple characteristics that, does that, if you have a sort of an additive score that gets you higher priority. Ruth, do you want to say a little bit more about that? Of you come from a minority population, you're an essential worker, does that move you up in the line?
Yeah, well, the question is, should it, right? Should it move you up in the line? And it to some extent, it will depend, I think the answer will depend on how much vaccine is available, how it's going to get rolled out, and how much discretion there will be at kind of point of administration over these sorts of issues. So if you think about a system like the Johns Hopkins health system, right? If we get one big allotment, and I don't know if anyone knows yet at the institutional level how that's going to happen, but let's just imagine that that's the case, and CVS gets a tranche, and who knows who else. That's part of the big deployment logistics issue that's being debated. It'll be a question, right, both of guidance, of discretion, judgment, and feasibility. How fine-grained the allocation criteria can be at point of service. So let me just step back for a little bit. Countries with as good a health system as the UK, and England in particular, are debating whether they can really prioritize by comorbidities. They're trying to figure out how that would actually look, right? Even though you would think with the National Health Service, like that should be super easy to do, because we have our fantasies about how well, everything in the National Health Service is just, easy, right? Because they know everything about everybody. But they're actually having an active debate right now about whether they can even allocate it by something as what we would think of as, basic and crude and relevant, and is in everybody's sort of top groups as comorbidities. And so age is easier. You basically can very quickly identify someone's age with a driver's license or anything of that sort. So that's pretty straightforward. But what is talking about gaming the system? I have whatever I have. I have diabetes. Well, prove it, right? Show it, right? How is the pharmacist at CVS going to be able to establish whether I have diabetes or not? Those are the sorts of issues that are we can have these sort of debates about how it ought to happen. It's going to have to sort of fit with how it might be able to actually feasibly be done. Now, in a health system, right, that's constrained, where we know a lot and where there's some level of trust, these issues with respect to health workers may in fact be something that we could take account of if we think we should, right? So I know there are many, and I'll stop, but there are many units who the last big wave, and now as we're coming into this again, had to think through what they should do with their older colleagues, with their colleagues that disclosed or everyone knew had a relevant comorbidity, with their pregnant colleagues. And this is not just at the professional staff level, it's at the support staff level and at the engineering level and so on. So within a community like a healthcare system, we may have more both opportunity and challenge to be more fine-grained in the sorts of moral choices that we will have to make for prioritization that might be able to be made if you're CVS or Walgreens, right? You're going to need much rougher criteria for deciding someone fits in a group, and a healthcare system could choose to go with the rougher if they decide that just seems simplest and fairest. But the challenge will be, well, is it, right?
Maybe I'll address this one. 95% efficacy with our latest news about the vaccine seems extremely unlikely. We cannot achieve that in a regular flu vaccine. What populations have been tested? So of that 30,000 that was in that group, who was included? And it mentions prioritizing pregnant women because of higher risk. And then in the prioritization, the tiers would also include teachers, and then obviously teachers that might become pregnant. But were they included in the research that was conducted on the vaccines? And how would you validate safety in a vaccine that seems to be rushed? In this idea of warp speed.
Right. And I will say that is an impression that we really have to counter. So I'm going to go through the questions one by one. The trials were very carefully designed to ensure that a third of the population was older than 65. So we have 18, essentially those 18 to 50, 50 to 65, 65 and older. Comorbidities and ethnic minorities were encouraged. I will say Operation Warp Speed has made that a priority for vaccine trials to make sure that we try to highly recruit those populations who have borne the worst of COVID. It's been a challenge gaining the trust of some of the communities, but overall, Operation Warp Speed has done a very good job in recruiting minority populations, and again, the elderly. We have also, as part of the recruitment, looking at people with comorbidities. So I will say the efficacy looks very good early on. Again, I do want to stress that this is very early efficacy. So we're looking at, probably 4 to 8 weeks post the last dose of vaccine. That's very early. We don't know if that efficacy will remain as high over time. But it is encouraging, at least with the Moderna vaccine, that we saw efficacy against severe disease. Now, that may be true of Pfizer as well. It just wasn't in the press release, and I don't have access, or could I speak of the confidential data. But I do think it's very encouraging, and I think it's real. This vaccine, this pathogen is different from influenza for a lot of reasons. So I do believe the efficacy. And I think what's really encouraging about it, this is a brand new vaccine platform that is showing great promise and actually could be extrapolated to other pathogens. So I think that that's really great. I do think there's several things in the trials that have been, that have disappointed me, I will say. One is there's requirement for at least the trial that I'm conducting to have highly effective birth control. So all women must be using highly effective birth control, which does not include condoms and spermicide, which means that a lot of people within the community who don't have access or can't afford birth control are not eligible for these studies. And then something I'm sure Ruth will want to comment on is that pregnant women have not been enrolled in these studies, and we don't know when they will be enrolled in these studies. The third point in terms of the safety, again, for all phase 3 trials, where we get our major safety is in the numbers that we enroll. And so I don't think safety is being sacrificed for speed. What we don't have and what we won't have before these vaccines go up for emergency use authorization or approval is long-term safety. And that again is a risk-benefit calculation. We feel it's more important to get these vaccines out there and try to stop the epidemic, the pandemic, and then monitor for long-term safety as we go along. And I'll stop there and see if Ruth wants to comment on pregnant women, because it's very important.
Yeah, it is. Thank you, Anna. And I don't, are we out of time though, Mark? I'm sorry, I can't hear you.
No, you're good. Please go ahead.
Okay. So, because I wanted to go right back and ask Anna to talk about the where she is in her thinking and her colleagues' thinking on the placebo arm and how we're going to get the long-term safety data in the absence of placebo. But maybe we can leave the last 2 minutes for that, because it's such a, not only an important research ethics question, it's a fundamentally important public health question, right? Public health ethics question. So yeah, pregnant women, it's really, really a challenge. My understanding, and I hope, Anna, that this is correct, is that at least a few of the companies are poised to begin to study their vaccines in pregnant women. I mean, we've been hearing this for a while, so we have to actually see it. I guess the down payment on this is that for the regulators generally require that preclinical studies with non-human animals, reproductive toxicology or DART studies be done before you can enroll pregnant women in any kind of investigational vaccine trial. And now we have some information that a number of companies have that. You would probably know better than I would, Anna, how many companies are how far along in their DART studies, but a couple of them are underway. And once they're completed, assuming they're favorable, there will be no more excuses. I mean, there'll be no more justification for not beginning to study these vaccines in pregnant women. But Mark, do you mind if Anna addresses the placebo question with the last?
Sure.
Yeah.
Sure, because it's something that we struggle with. And there was an article in the New England Journal by Marianne Gruber and Phil Krause, who are at CBER and FDA wanting to maintain the placebo group. I think there's a couple things. So with one of the concerns early on about COVID was this enhanced disease upon subsequent exposure to natural infection. What I will say, and what I think most investigators feel, is that the risk of getting COVID and possibly severe COVID, if you're not vaccinated, is far, far greater than the risk of getting an enhanced disease down the line. We will continue to monitor people for at least 2 years, whether they were got vaccine originally or placebo, and those long-term studies will continue. So we will have long-term safety data. It's true we won't have a placebo group necessarily to compare it to, but I think if there is a safety signal, that will be identified. Our concern is that we're asking people who have been enrolled in these trials because they're at higher risk of COVID, because whether it is their lifestyle, their work, underlying comorbid conditions, they are at higher risk for COVID. And we feel that if there's an efficacious vaccine, we cannot prevent them from getting that vaccine because they're putting their health at risk. And what the CoVPN or Operation Warp Speed is planning is to do a crossover design where we keep the placebo and the vaccine groups blinded, but everybody will eventually get vaccine. So the placebos will get vaccine, the vaccinated group will get placebo, and we won't know who's who, but we'll follow all people out for at least 2 years. What's even a bigger problem, I think, Ruth, is in these trials coming down.
I know
He's
the
coming,
new trials.
the new trials, what's going to happen with the new trials, exactly.
Yeah.
Maybe the last word, Ruth, on sort of the international perspective, two questions about that in terms of how do we make the vaccine, so we have it in the United States, how do we make it more accessible, available in other parts of the world? And two, the work that advisory groups here are doing for any kind of ethical frameworks, how do those get promulgated internationally?
So And just a lovely overview of the National Academy's report. One of the recommendations in the National Academy's report is that there be it's an explicit recommendation that the U.S. essentially contribute to the global effort to secure vaccine equity, or at least approximate vaccine equity, either directly by contributing to something called the COVAX facility, which is a new entity that has been established. The WHO, Gavi, and something called CEPI. We don't have time to decode the initials, but it's this massive new effort that is unique to this pandemic to try to, as rapidly as possible and with as much of a global equity base, distribute vaccine that can help contain this pandemic everywhere in the world. That's never been attempted before. Right now, the U.S. has, under this administration, has not contributed at all, or is not a participating country. The WHO, of course, in its guidance, have both recommended that the U.S. and other countries join the COVAX facility and or otherwise provide direct assistance or bilateral aid to countries who are not positioned to get all the vaccine that they need for their own citizens directly. There's like really good self-interested reasons for high-income countries to do this, not only public health self-interested reasons, but economic recovery self-interested reasons. And also just as a matter of global, the principles that Anne laid out are all also true at the global level. Equity concerns apply as well globally as they do, well, for some of us apply as well globally as they do within countries. And it's a very, very serious concern. The World Bank has stepped in recently and is now offering substantial amounts of resources to help countries negotiate bilateral agreements with manufacturers. But it's not only money, it's also the fact that the US and other wealthy countries have locked up a substantial amount of the doses that are going to be initially prepared. So Anna, you may know, I keep saying Anna because that's how my granddaughter pronounces the name. It's Anna, right? For most people in the world. And Anna knows I do this. So I apologize. But Anna, do you have a sense, for example, for the two vaccines that you're working with, companies that you're working with, how much has been locked up by the US of their initial production capacity?
So from what I understand, almost all of it, at least for the first couple rounds, which they anticipate will be ready in, end of December, January, early February. And we're only talking total about 20 million doses from each company. And there are 2-dose vaccines, which means that you're down to 20 million people being vaccinated. Now they are hoping to scale up production. I will say that Pfizer is doing the study internationally, so they're doing a lot of the study in South America. Yep. So hopefully Pfizer is allocating some vaccine, and they are not part of Operation Warp Speed. So, and AstraZeneca is also doing the study internationally in cooperation with Oxford, so should have some. But the future ones, I'm not. The future, Janssen is an international company, so they also will have some, but it's unclear just how much.
Okay, great. Well, we're at time. We didn't get to all of the questions, but I want to thank our panelists for great information about the vaccine, and look for a summary on the Berman Institute website. We'll include details about any of the other questions we didn't get to. Thank you all.
Thank you. Bye, everyone.
Thank you.